بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, we are continuing our chest sector imaging, and we have finished the lecture about how to interpret the chest x-rays, and also we finished with the way of how to interpret the CT scans of the chest. Now we are going deep into the subject, and we'll discuss some of the important topics. One of them is the imaging and the staging of lung cancer. And of course you all know that the intimate relation between smoking and the lung cancer, which is considered one of the most common causes of deaths worldwide. And the smoking is considered the major risk factor, accounting for 90% of the associated habits that may lead to the development of lung cancer. Actually, you all know that we have three main histologic groups of lung cancer: the small cell lung cancer, the non-small cell lung cancer, which includes the adenocarcinoma, the squamous cell carcinoma, and the large cell carcinoma. And we have finally the undifferentiated lung cancer. Then the role of imaging is to characterize the primary lesion and to assess the local relationship of the lesion to the pleura, to the chest wall, to the mediastinum, and to the airways. Then to assess the distant tumor spread, giving metastasis to bones, to brain, to liver, as well as the suprarenal glands, being one of the most common sites for metastasis from lung cancer. Then these are the plain radiographic signs of bronchogenic carcinoma. Number one, you may have a peripheral nodule with a speculated margin, and we have discussed this in the topic of how to interpret the chest x-rays. Or one of the major findings, enlarged dense hilar shadow, unilateral. Then a pulmonary mass of whatever age in an adult. Also we discussed this in the sector of plain radiographs. Then a central lesion with ipsilateral diaphragmatic elevation due to phrenic nerve paralysis, consolidation collapse due to bronchial obstruction, especially in adults, and malignant pleural effusion, and finally the eighth sign of Golgi. And I'll give you some of these examples. This is the chest x-ray of a male smoker with hemoptysis and hoarseness of voice. In the left lung, mid-lung zone, you can see a well-defined lesion with a speculated margin, and is suggestive of being a lung cancer or a bronchogenic carcinoma. It was proved to be a non-small cell lung cancer. Then this is the mass in the left lung, and I have emphasized the importance of diagnosing a mass in the lung of an adult as a bronchogenic carcinoma until proved otherwise, because you have the diagnosis, the differential diagnosis is limited, especially if you see a mass in the lung of an adult. As I have said, then you consider bronchogenic carcinoma first possibility, and if this lesion is proved by CT or ultrasound to contain water, you consider hydatid cyst. Or if the patient is known to have a primary malignancy or the lesion is multiple, then you may consider metastatic deposits. And this is an example of central bronchogenic carcinoma with bronchial obstruction and left upper lobe consolidation collapse. This finding is very important in adults. It can occur in the pediatric age group due to mucus plugs, due to foreign bodies, and many other causes. But if you see a central lesion with lobar collapse or consolidation collapse, then you think of malignancy until proved otherwise. And here you can see soft tissue density superimposed on the left hilum with homogeneous opacity in the left lung field proved to be in the left upper lobe in the lateral view. And also you can see the ipsilateral diaphragmatic elevation. And this is an example of a enlarged dense hilar shadow on the left side, and this is suggestive of bronchogenic carcinoma, especially if you see that the ipsilateral diaphragm is also elevated. Then the CT scan show the lesion, which has developed central breakdown, and the margin of the lesion is very thick, and also you can see the irregularity of the inner margin. Then the S sign of Golden is simply a central bronchogenic carcinoma that has resulted in lobar collapse consolidation. And if you can imagine the letter of S, and this is the border of the collapsed lobe, and this is the curve of the S formed by the central bronchogenic mass. Then the remaining of the letter S is the mediastinal border below the level of the bronchogenic carcinoma. This is one of the findings that you may see in the plain film, and based on this, and you consider a central mass with lobar collapse in an adult as a sign of bronchogenic carcinoma until proved otherwise. Then if you have the CT scan and you can see clearly the edge of the lesion, you can also identify if there is calcium or not, and you can also assess exactly the contents of the lesion, whether it is solid or cystic. Then this is the classic appearance of a peripherally located pulmonary nodule showing the speculated edge, characteristic of malignancy, compared to the benign lesion, which has a smooth margin, and it contains a central area of calcification. This is the appearance of a benign lesion, and this is the appearance of a malignant lesion. Then the peripheral bronchogenic carcinoma is a lesion which has a speculated margin, may be related to one of the vessels or also one of the bronchi. It may show some extensions to the adjacent pleura, what we call the pleural tail, but all these signs are not pathognomonic. If you see a lesion, a pulmonary nodule, peripherally located with a speculated margin, and you think of peripheral bronchogenic carcinoma. And if you remember, I have said that there are 6 common pulmonary nodules, and I provided to you in the previous lecture the differential diagnosis. The 6 common pulmonary nodules are the tuberculoma, hamartoma with a smooth margin, may contain calcium; bronchogenic carcinoma with a speculated edge, does not contain calcium usually; metastases, which are multiple or solitary, and the patient is known to have a primary malignancy; arteriovenous malformation in a nodule connected to the hilum by 2 cord-like structures representing the feeding artery and the draining vein; and also the hydatid cyst, which is the only nodule or mass in the lung containing water. Then bronchogenic carcinoma is differentiated from all these nodules by the speculated margin, which is very important. One of the important differential diagnoses for a bronchogenic carcinoma is the pulmonary arteriovenous malformation. Actually, the difference is usually clearly seen on imaging, but sometimes you cannot elicit the findings to support your diagnosis as a pulmonary arteriovenous malformation. Then the next step of seeing a pulmonary nodule of indeterminate nature is to take a biopsy. And if you have biopsied the pulmonary arteriovenous malformation, and this is catastrophe, then it should be you should be very careful in interpreting pulmonary nodules, especially as regard the arteriovenous malformation. If there is any doubt, you may have a CT angiogram and to confirm your diagnosis, or you inject an adequate amount of contrast and you do multiple reformatted images to be sure that this lesion is not an arteriovenous malformation. Then the masses of whatever age and whatever matrix are considered as bronchogenic carcinoma until proved otherwise in adult person. Then you see a mass here, and this mass has invaded the mediastinum, going posterior to the trachea and also posterior to the superior vena cava, which is compressed, and this is the central bronchogenic carcinoma. And this is a mass of a speculated margin or lobulated margin or a smooth margin. It does not make a difference. A mass in the lung of an adult should be considered as a bronchogenic carcinoma until proved otherwise. Then if the mass contains calcium, calcium does not indicate or has no significance in the diagnosis of bronchogenic carcinoma. And you see here a mass in the lung containing calcium of an adult diagnostic of bronchogenic carcinoma. Calcium is important in the nodules. Calcium in the nodule means a benign lesion. Calcium in the mass has no diagnostic significance. Then you see here a mass with areas of breakdown, flecks of calcium, and this is also a bronchogenic carcinoma. Then you remember that I have said in the lecture of chest x-rays that the two cavities with a thick margin containing air may represent an abscess and a cavitating bronchogenic carcinoma. This means that the bronchogenic carcinoma may cavitate, and the patient may expectorate the shreds of the tumor, and you are left with a cavity with thick margin. And the difference between this cavity and the lung abscess is that the inner wall of the bronchogenic carcinoma is extremely irregular, while the inner wall of an abscess is smooth. Then you may have other findings to support your diagnosis of bronchogenic carcinoma, as mediastinal lymphadenopathy, for example, and the metastatic disease elsewhere. Then if you see a mass like this, and you should say that this is a bronchogenic carcinoma in the lung of an adult. And the patient did not have any kind of treatment and refused the biopsy and came after 3 months for follow-up. Then you see that the lesion has developed a central cavitation with necrosis, and you see the thickness of the margin and the irregularity of the inner wall. This is not, of course, an abscess. This is a cavitating bronchogenic carcinoma. Also, you remember that one of the differential diagnoses of a cavity with a ball inside is a necrotic tumor. And if you see an appearance like this, thick margin with irregular inner wall of a cavity, then you consider malignant cavity, whatever its contents. This malignant cavity may contain only air, may contain a mass and air, this is the shreds of the tumor, and may contain air fluid level as well. And all these findings are considered, are not considered in the diagnosis if you see that the lesion has a thick margin with irregular inner wall, indicative of being a malignant cavity. Also, you can easily appreciate the enlarged mediastinal lymph nodes nearby to the cavity. And the 4 diagnoses for a cavity with a ball inside: number 1, and by far the most common, is the fungal ball, then the chronic rupture of the hydatid cyst, necrotic tumor, and the blood clots. And if the cavity has malignant criteria, that is to say thick margin, irregular inner wall, then you consider malignant cavity, whatever it contains a ball or there is no a ball inside. And this is an example of a bronchogenic carcinoma with a mass and air fluid level inside the cavity. And you see a big cavitary lesion in the left lung with the soft tissue mass along its margin as well as air fluid level. The CT scan showed the thickened margin, the irregularity of the inner wall, as well as the internal air fluid level within the lesion. Then you have to characterize the malignant lesion, whether it is central or peripheral. Then we start by the peripheral mass, and the peripheral mass may invade the chest wall, and you have to specify this in your report considering a malignant lesion. Then we have too many signs of a chest wall invasion, but the most reliable of them on CT scan are two. Number one, rib destruction. Number two, tumor extension beyond the chest wall. And if you look to this mass, which is seen in the lung of a male patient 70 years old, diagnostic of a bronchogenic carcinoma, and the mass is intimately related to the pleural surface and the inner aspect of the chest wall, and this is not enough for diagnosis of a chest wall invasion. When to diagnose this? Whenever you see that the adjacent rib is destroyed, or you see this tumor is outside the outer margin of the rib, then you know that there is a chest wall invasion. Like this case, and you see a mass in the anterior part of the right upper lobe, then you see the mass has invaded the chest wall, and the soft tissue tumor is found extrathoracic, and the rib here is destroyed, and part of the sternum is also has been destroyed. Then the literature says that MRI is more accurate in diagnosis of a chest wall invasion by bronchogenic carcinoma compared to the CT scan, because the tumor in the T2 weighted image will show some brightness because of its water content, while the chest wall muscles and ribs will appear black in T2 weighted image. Then you can easily discriminate the difference of the signal behavior between the tumor and the muscles of the chest wall. And then if you see that the tumor has extended into the fat outside the thorax, in the axilla or in the subcutaneous area, then it's easy to say that. A chest wall invasion was a previous contraindication to surgery of bronchogenic carcinoma. But nowadays, as I know from the thoracic surgeons, that the chest wall invasion is no more an obstacle to remove the tumor. They can remove the tumor as well as the infiltrated chest wall together. Then one of the well-known types of the bronchogenic carcinoma invading the chest wall is the Bankus tumor or the superior sulcus tumor. And the Bankus tumor is diagnosed by the presence of a mass in the apex of the lung associated with some destruction of the adjacent ribs. And this is one of the tricks in the exams, and you have a lesion which may be smaller than this, and you forget to look to the adjacent ribs. Any opacity in the lung adjacent to the ribs, you should verify the state of the ribs, if they are intact, if they are eroded, if there is fracture, and this is very important, leading you to the accurate diagnosis. Then a lesion in the apex of the lung, and you see that the second rib is destroyed from here along its course, and this is the third rib, and part of the first rib has also been destroyed. Whenever you see this, and you think of a Bankus tumor, then you may see a Bankus tumor, but you can appreciate that the ribs are more or less intact. This does not contraindicate the diagnosis of Bankus tumor, and you should have a CT scan, because CT is more sensitive for detection of bone erosion, and also more sensitive for detection of chest wall invasion and extrathoracic extensions. And here's an example. You see a mass in the apex of the right lung, and this mass has extended outside the chest, invading the chest wall muscles with destruction of the related rib compared to the intact rib on the left side. Then MRI is one of the important tools for assessment or preoperative assessment of Bankus tumor. Then MRI is sensitive, as you all know, in evaluation of invasion of the brachial plexus, and also invasion of the spine with intraspinal extension and the compression of the cord. And very importantly, you should identify the relation of the Bankus tumor to the roots of the brachial plexus, to the subclavian artery, and to the subclavian vein. This relation will decide whether this tumor is operable or inoperable. And the fact of being invading the subclavian vein or artery or the brachial plexus nerve roots can be only evaluated accurately in the sagittal MR images. As you can see here, this is a tumor in the apex of the lung infiltrating the lower neck, as well as the apex of the right of the lung, and along the anterior chest wall. This is the clavicle, and here is the roots of the brachial plexus, and this is the subclavian artery, and this is the subclavian vein. Then this tumor has invaded the brachial plexus, and it may go a little bit around the subclavian artery with no affection of the subclavian vein. And the encasement of these vessels is one of the contraindications to surgery. CT scan is unable to provide these informations, but it can certainly help in the diagnosis of Bankus tumor. As you can see, a mass in the apex of the lung destroying the adjacent ribs as well as the vertebral body with intraspinal extension, as you can see here, compressing the spinal cord. Then invasion of the stellate ganglion in the lower cervicothoracic sympathetic nerve plexus will result in a famous syndrome which is known as Horner syndrome. And this syndrome is composed of ptosis, meiosis, and hydrosis. These findings actually are not usually seen in the clinical practice nowadays as a signs for Bankus tumor, because this is a very late manifestation of the tumor, and the tumor can be identified so early than this whenever it invades the ribs, for example. Then you see this is a coronal reconstructed image showing a Bankus tumor partly in the lower neck and partly in the upper chest. Then the central lesion may invade the airway or may invade the vessels. And invasion of the airway may result in obstruction of one of the bronchi with consequent distal consolidation collapse of the lobe. Then one of the major disadvantages of CT is that it can not separate the margin of the tumor from the margin of the consolidation in many cases, because the tumor has almost the same density to the adjacent consolidation. Then if you look to this an example, and you see here some consolidation collapse with no air bronchogram, of course, because air is absorbed due to malignant obstruction, and you see the lesion as well, but you cannot separate the tumor from the consolidation. And this is the value of MRI to separate the tumor from the consolidation, especially in the T2 weighted image. And you see this tumor, and this is the consolidation. The tumor and consolidation cannot be separated in the T1 weighted image, but in the T2 weighted image, because of the difference of the water content, consolidation contains more water than the tumor, of course. Then you can see the tumor of intermediate signal and the consolidation of very high signal, as you can appreciate. Then invasion of the mediastinal vessels will contraindicate surgery, of course. If you have a tumor with invasion of the pulmonary artery or encasement of the pulmonary artery, and the tumor has totally encased the left main pulmonary artery, which is now markedly narrowed, as you can see here. And this is the bronchogenic carcinoma surrounding or encasing the left main pulmonary artery, which became thread-like compared to the right main pulmonary artery. Then you see the mass, you see the metastatic lymphadenopathy and retrocaval metastatic lymph nodes as well, prevascular lymph node metastasis as well. Then invasion of the mediastinal fat does not contraindicate surgery, but invasion of the vessels or the bronchi especially near to the carina, will contraindicate surgery. And this is the mass which is invading the mediastinal fat, and the arrow points to one of the enlarged lymph nodes. But you don't see invasion of the aorta, nor the superior vena cava, nor the descending aorta, nor the mediastinal bronchi. Then invasion of the vessels contraindicates surgery. This is the bronchogenic carcinoma. This is the arch of the aorta, and you cannot see the superior vena cava, which has been totally occluded by the tumor. And this is the bronchogenic carcinoma invading the left atrium. You see the tumor extension inside the left atrium. Then we came to the mediastinal lymph nodes, and actually the lymph nodes are diagnosed by the size in most of the cases using CT and MRI. The cut-off size of 10 millimeter for the pathologic lymph node will result in about 60% sensitivity of these imaging techniques, provided that 13% of the normal sized lymph nodes may contain tumor tissue, and 37% of the nodes, which are measuring about 2 to 4 centimeter, may not be malignant. Then detection of the calcium by CT in the lymph nodes is indicative of benign nature or inflammatory etiology, while the PET CT is now considered the most sensitive technique for assessment of lymph node involvement by bronchogenic carcinoma. And you remember I have mentioned the nine groups of mediastinal lymph nodes in the previous lecture of CT scan of the chest, and we'll revise them very quickly. The retrosternal group of lymph nodes are located behind the sternum. The retrocaval lymph nodes are located behind the superior vena cava. The prevascular lymph nodes are arranged along the arch of the aorta. The aortic window lymph nodes are located between the ascending and the descending aorta above the pulmonary artery. The carinal lymph nodes are seen anterior or posterior to the carina, while the subcarinal lymph nodes are located between the two divisions of the trachea. Then the hilar lymph nodes are located in the hilum. The zygoesophageal lymph nodes are related to the esophagus and the azygos vein. They are called the posterior mediastinal lymph nodes. And finally, the circumcardiac lymph nodes, which are arranged along the pericardium, sometimes associated with pericardial effusion. And I should emphasize the relationship between this group of lymph nodes and the non-Hodgkin lymphoma. Then mediastinal lymph nodes may be of normal size, then you cannot see by CT or MRI. And the PET scan has now an important role in the identifying the metastatic lymph nodes prior to surgery of bronchogenic carcinoma. Then this is the nodule, which has been proved to be a bronchogenic carcinoma because of its high uptake in the PET scan, and the arrow points to the metastatic lymph nodes in the mediastinum. One of the most important diagnostic tools in the management of bronchogenic carcinoma is the percutaneous transthoracic needle biopsy. And why we do the biopsy? As you know, that the diagnosis of bronchogenic carcinoma many times is easy, but you should have a biopsy even whenever you are 100% sure that this is the bronchogenic carcinoma, in order to confirm the diagnosis first and to know the cell type of the tumor, as I have mentioned before. Then CT-guided needle biopsy is a simple maneuver. It requires some skills to be performed accurately without doing harm to the patient himself. Then the criteria of optimal procedure: then you have a peripheral lesion which is very close to the chest wall, and the lesion size is more than 2 centimeters in diameter, and you can approach the lesion in a perpendicular pathway, especially from anterior or from posterior. This an oblique pathway is not usually easy like the perpendicular pathway. Then you select one of the suitable needles, and I recommend for the lesions which are in close proximity to the chest wall a gauge of 16, and for those deeply situated in the lung the gauge of 19 or 18 in order to have a good core which can be evaluated by the lab. Then there should be no obstacles in the needle way, like a rib for example, or an osteophyte from the spine or the sternum. Then there should not be a major vessel in the root of the needle, and also there should not be any emphysematous bully, because this will increase the incidence of post-procedure pneumothorax. Actually, the pneumothorax happens in about 1/3 of the cases, but this pneumothorax is usually limited, very small amount, and it resolves spontaneously. And sometimes in about 6% of these 30% cases may develop a rapidly accumulating pneumothorax, and they require an intercostal tube. This is common in patients with COPD or very old patients. If the lesion is very deep and you have done multiple trials, or you wrongly select a gauge which is larger than 19 gauge. Then hemoptysis will result whenever you transverse the lung by the needle, reaching the target of interest, and the hemoptysis will increase if the incidence of hemoptysis will be larger if the coagulation profile is not accurate. Then in order to assess the distant tumor spread, the adrenal metastasis, the adrenals and the brain are very common sites for metastasis by bronchogenic carcinoma. This is the mass in the right lung associated with pleural effusion, and the mass is solid, infiltrating the superior vena cava, and the upper abdominal section showed bilateral huge masses in the suprarenal glands representing metastasis. Then we used in our clinical practice, whenever we are encountered by a patient presenting by brain deposits, multiple lesions in the brain representing metastatic deposits surrounded by a considerable amount of brain edema, and we do not know the primary pathology in this patient, then the first site to look in is the chest. And we used to do so, and if we are encountered with a patient with brain metastasis as a first presentation, we should look in the chest by plain X-ray, and many times we can elicit the primary malignancy. That's to say, in the bronchogenic carcinoma or the brain is one of the common sites for metastasis from the bronchogenic carcinoma. And this is the brain metastasis from bronchogenic carcinoma by CT and MRI T1, MRI T2 coronal and axial. Then we came to the tumor staging, and actually this tumor staging is important if you have good clinical relationship with the surgeon. He sometimes asks you about the stage of the tumor, and to help him to take the decision of surgery or not. Then the stage 1 is a tumor less than 3 centimeter in diameter, not invading the mainstem bronchi. The peripheral lesion with a speculated margin less than 3 centimeter in diameter, not associated with bronchial invasion, and no evidence of pleural effusion or metastasis, for example. Then the T2 tumor is a tumor more than 3 centimeter, meaning that it is a mass with invasion of the pleura if it is peripherally located, or invasion of the bronchi if it is centrally located, provided that the invasion is far from the carina by a distance more than 2 centimeter. Then this may also help in surgical excision. Associated atelectasis, which is not involving the whole lung, is involving the bronchus, which has been invaded by the tumor. Then the T3 tumor is tumor of any size with invasion of the pleura, the chest wall, the diaphragm, the pericardium, invasion of the bronchi by a distance less than 2 centimeters from the carina, or atelectasis of the whole lung. Then T4 tumor is a tumor of any size with invasion of the mediastinum, invasion of the heart, invasion of the spine, invasion of the major vessels, or associated with malignant pleural effusion. Then the lymph node staging, actually you know that if there is no nodes, then this is the best prognosis for the patient. But in one lymph nodes, meaning that ipsilateral mediastinal lymphadenopathy affecting the peribronchial and the hilar region, like this you can see here. But in this is in T1, in T2 with in N2 lymph nodes, the nodes are more involved, especially in the mediastinum, in the subcarinal area, and these patients, as the literature says, will not benefit from surgery. N3 meaning that there are contralateral lymph nodes in the opposite side of the tumor, affection of the hilar lymph nodes, mediastinal, supraclavicular lymph nodes, and these patients are not candidates for surgery. Then why to do a biopsy from a mass which is present in the lung of an adult? Number one is to confirm the diagnosis, and number two is to know the cell type of the bronchogenic carcinoma. And this is one of my cases I have examined myself, and you can see here a mass in the right lung. The CT scan showed a mass which is present in the right lung, and I suppose that this mass should be a bronchogenic carcinoma, and I recommended the CT guided needle biopsy. I took the biopsy, and the result was a pulmonary lymphoma. Then one of the lesions that can arise in the lung is the lymphoma, and the lymphoma I will discuss in full details after that. But in order to give a hint, if you see a lesion like this, which is a nodule or a mass which is containing air bronchogram, then there are three main differential diagnoses. Number one is round pneumonia, particularly if in the pediatric age group, and alveolar cell carcinoma and the pulmonary lymphoma. These are the possibilities for a nodule or a mass containing air bronchogram. Then alveolar cell carcinoma will be discussed in full details in the sector of, or in the lecture of, diffuse lung disease. But one of the important manifestations of alveolar cell carcinoma in the lung is the presence of pulmonary areas of consolidation together with pulmonary nodules in the same lung or in the opposite lung, because you know that these nodules are the precursor of these opacities. And alveolar cell carcinoma may present by miliary pulmonary nodules, may present by batches of consolidation, which difficult to be differentiated from pneumonia, for example, and you may have diffuse airspace disease with micronodularity. I will discuss this in full details whenever I am talking about the issue of diffuse lung disease, and I thank you very much.